Doctor, what has been your experience when it comes to the effectiveness of carbetocin versus oxytocin for the prevention of postpartum hemorrhage?
In terms of the supply chain? Perhaps because of this, and also perhaps because of the fact that carbetocin is an extraordinarily efficacious drug, our personal experience has been that carbetocin is extremely effective for the prevention of PPH. In fact, in our clinic, since almost the past 7 to 8 months, we have not used oxytocin at all for prophylaxis of PPH for even a single patient. All our patients who deliver get RTS carbetocin, and we either administer it intramuscular or intravenous. Whether it is a patient of a vaginal birth or a C-section, we have found that carbetocin is equally effective as well as safe for both these group of patients. I do not have data on the comparison between oxytocin and carbetocin in my practice, but I can refer you to several studies in the literature, which would demonstrate that at the very least, carbetocin is at least non-inferior to oxytocin. And we use the word non-inferior consciously because, for example, the Champion trial was designed to look at non-inferiority. But if you look into the data a little carefully, it does actually demonstrate a certain amount of superiority and also has the advantage of being room temperature stable. I think one thing which has perhaps not been paid enough attention to in the findings of the Champion trial is that although this trial was a comparison between oxytocin and carbetocin, the oxytocin that was utilized in the trial was used in a trial mode, which means it was made sure that this oxytocin is stored properly, the cold chain is maintained properly, and so on and so forth. And I think, to my mind, this does not reflect a real life situation where the cold chain may not necessarily have been maintained in the best possible way. So, our personal experience, as I said, since the past several months, we have not been using oxytocin as a prophylaxis for PPH. We found carbetocin to be extremely safe and extremely effective.
Could you mention about your experiences related to the additional need of uterotonics, uterine massage, and blood transfusion with carbetocin when compared to other uterotonics?
Again, I don't have published comparative data, but subjectively, I can say that it seems that carbetocin, the use of carbetocin in our practice has reduced the incidence of PPH and most certainly the incidence of severe PPH. Do I need to use additional uterotonics or any other kind of measure uh, in a larger way after switching to carbetocin? The answer is definitely and most emphatically no. In fact, carbetocin seems to work remarkably well. And I do believe that the current literature actually shows that the routine use of carbetocin will perhaps reduce the number of PPHs or the number of patients who suffer from PPH will considerably reduce with the use of carbetocin. And I think the introduction of carbetocin will probably mean a paradigm shift in the management of PPH in terms of, particularly in terms of conservative surgical management of PPH. You must understand that a lot of the conservative steps or the conservative managements of PPH were suggested at a time when the uterotonics that we had were not as effective as the uterotonics we have now. And it therefore needs to be considered that if the current uterotonics do not act, should we then even try for conservative management, or is that patient automatically choice, is that patient automatically a candidate for an obstetric hysterectomy rather than? I know this is a little controversial and there's no literature to substantiate this, but I strongly believe that in the future, that's what will probably happen given the high efficacy of the uterotonics that we have now.
And how has your experience been with the use of carbetocin in vaginal deliveries?
As I already said, we don't differentiate between vaginal deliveries and C-sections. We use carbetocin for everybody. I honestly do not understand the hesitation of using carbetocin in vaginal births. In fact, if you look at the Champion trial, which is supposed to be the trial for the use of carbetocin, the entire trial centered around vaginal birth. So there is more and enough data already to talk about the safety of carbetocin around vaginal birth. It speaks to me perhaps of the kind of resource settings that we work in, because a whole lot of patients in our country, a whole lot of women in our country deliver in private nursing homes, where the number of the human resource may not be as much as there is in a big hospital. And therefore, the presence of an anesthetist at the time of C-section is looked upon as an additional hand to help in case something happens. But honestly speaking, I really don't see why there should be hesitation in using carbetocin for vaginal birth. As I said, most data seems to figure more on vaginal birth than C-sections, and we have been using carbetocin for both vaginal birth and C-sections. And just to give a context of how much carbetocin we have used, we do around maybe 40, 45 deliveries a month, and we have been using carbetocin as the sole agent for prophylaxis. Again, let me reiterate, prophylaxis of PPH for close to, I think, 10 months or so now. I don't remember the exact number, but it's been a long time since we use carbetocin exclusively. So that's an experience of, quite a decent number of patients. Yeah.
Doctor, would you recommend the use of carbetocin for the prevention of postpartum hemorrhage in every delivery?
Well, there are some contraindications, I believe, which have been outlined in literature. And besides those very, very limited contraindications, I would be very comfortable in saying that carbetocin should be used for all deliveries. I really see no reason why we shouldn't.
Doctor, any additional points of views that you would like to share regarding the use of carbetocin through your experience of so many years with using this drug?
Yeah, I think there are two or three questions which I always get asked when I speak on carbetocin, and I do speak on it quite frequently. One question I get asked is, can you use carbetocin immediately where you used oxytocin for the augmentation of labor? The fear, of course, is that the residual oxytocin and carbetocin will have a synergistic effect and create a side effect. The answer is you can use carbetocin even if you used oxytocin for augmentation, because the dose that you use for augmentation of oxytocin is very small. It's given very slowly over a prolonged period of time. And because the half-life of oxytocin is very short, there will not be any synergistic kind of a side effect. Another question I'm asked quite often is, can you repeat a dose of carbetocin? The answer is that although safety studies have demonstrated that you can repeat a dose of carbetocin, there is no clinical data available as of now to say that you should repeat a dose of carbetocin if the first dose for some reason does not work. And I think the last question I get asked very often is, can you use carbetocin for the treatment of PPH? Logically speaking, I think you should be able to use it. However, there's no clinical data to show that carbetocin should be used for the treatment of PPH. Right now, what the recommendation is that use carbetocin for the prophylaxis of PPH. And despite the use of carbetocin, if you do have PPH, then you can use any other uterotonics in the dose that you would otherwise routinely use even if you're given carbetocin.